absolutely. Okay, are we I think we should dive into treatment because this is
Okay.
where the toolbox is enormous. And I have found because there's no protocol. There's no one size fits all in my experience. I really want to hear what you're doing with your patients. There are some baseline standard things that work, but it doesn't work for every patient. And that is really the biggest challenge. There's an art to managing patients, to helping patients with MCAS, truly. And you have to be willing to um, kind of think outside the box and also treat off label quite a bit. So tell us what you do.
Everything's off label. There's
Every
no approved, FDA approved drug for MCAS.
Mhm.
I don't even think there's an approved drug for mastocytosis either, but they are experimenting with anti-malignant therapy. But you
Yes.
don't have to do that primarily with MCAS. A few exceptions I'll talk about. But basically, there are very few studies that have looked at therapy for MCAS. There's one study for Xolair, and it was a small study, but it did help multiple symptoms in MCAS. And that's Xolair is like a step four therapy. You have to have refractory hives, asthma, food allergy of the IgE type, and anaphylaxis. So it's limited to prescription by the allergist. Basically, the the insurance companies don't want to see anybody just prescribing it unless you're an expert in Xolair, which is okay.
Hmm.
So that's when I refer to an allergist. I want them to get Xolair, and that's when I refer to them. There's other issues to do so, but it's questionable. Anyway, the gastroenterologist, the nurse practitioner, the physician's assistant, the internal medicine doctor can treat patients with MCAS. You don't have to refer them out. And it's quite satisfactory that you can ask the patient what are your triggers and hand them a list and give them a list, and Dr. V is going to give you the list that I came up with for patients and how to get treated, to look for food intolerance. And I only say 3 weeks, no dairy, no gluten, low histamines, 3 weeks, and then challenge yourself and see how you do.
Hmm.
I don't say, go off all foods
For
and
life.
no
Yes,
limit
I love
diet,
this.
and then, somebody who has, an eating disorder gets worse because of
Hmm.
that. I don't do that. That's not right.
Hmm.
And is rarely ever needed. But the patients do need to say, okay, this, while I'm not on any treatment, this will make me sick. Okay, so that is an issue. But those problems, like I saw somebody a week ago, now that they're under control, I can have tomato sauce. I could never have it before because I'd have a flare because it's a high histamine food.
Hmm.
But, with a good therapy, so what is good therapy? I start with the basics.
Hmm.
Step one, and that's in the handout you'll get if Dr. V puts
I
it up.
will share it. I will. It's a wonderful handout. I will absolutely share it. Thank you for
So
allowing me.
that's my approach. Here's my approach to MCAS for therapy.
Hmm.
It's looking for triggers, whether it be food, heat, uh, seasonal allergies, etc. Look for long-standing, long-acting triggers. So that would be tick-borne infections, mold exposure, gigantic, especially in Houston. Mold
Hmm.
is there. Uh, in St. Louis, plenty of mold.
And you're getting this through history alone, Doc. Are
Oh,
you?
absolutely. Then I,
Not,
of course, test
yes.
them,
Okay.
and get them out of a bad house
Hmm.
right away. Have them take a vacation. Do you get better? Yes, many people do.
What mold testing are you doing? What type of mold testing?
I do the blood work, my
Okay.
micro lab. I'm not
Okay.
an investor or anything, but I think it makes sense. I did write a little article about it, but basically it tells your self that your body is really reacting against the mycotoxin
Mhm.
because you have immunoglobulin positivity. Okay, so let's go back to step one therapy. So you are dealing with what are the triggers. Do they have chemical triggers? Do they have amalgam? Do they have metal in their body that's making them worse?
Hmm.
Then I say, okay, antihistamines, H1, H2 blockers. You'd think that's a big winner, but it doesn't always fit, and some people get worse because they're allergic to the excipients in them.
In the antihistamine, yeah.
But if you actually look at a publication this year from our group, neuropsychiatric disorders in MCAS and effect of mast cell therapy, just Google Weinstock neuropsychiatric and mast cell activation syndrome, and you'll come up with that. And we looked at three drugs to see how effective it was from the perspective of the patient globally, and also specifically to certain neuropsych disorders. Um, so we looked at H1, H2 blockers, we looked at low dose naltrexone, and we looked at benzodiazepines, which can be very helpful. And there are four studies in the lab showing that benzos reduce mast cell output of histamine and activation. And yet it's controversial because nobody wants to prescribe those
Hmm.
for a variety of reasons, but it's actually not totally legit when it comes to a very difficult situation like MCAS,
Hmm.
severe. Okay, so antihistamines, vitamin C, vitamin D. Make sure your vitamin D levels are high.
Hmm.
Then, nu- nutrient, nutraceutical use of flavonoids.
Hmm.
Flavonoids are basically chemicals that reduce mast cell activation, and they include quercetin and luteolin, also
Uh-huh.
as well, and bromelain, and also an herb called berberine. So these things actually reduce mast cell activation syndrome.
Hmm.
And luteolin goes into the blood-brain barrier, across the blood-brain barrier, and can help with many different things.
Yeah.
And Theodocles even looks at it in autism. Many of the
Yeah,
autism
Dr.
kids
Theo's
have
looking at it
mast
on
cell
autism.
symptoms.
Yeah. Yeah. What?
And I'm seeing actually three patients who decided to get tested by a psychiatrist, and lo and behold, in their adulthood, realized that they were autistic.
Mm,
Interesting.
yeah.
Um, and then LDN. I introduced that early on. It's inexpensive, and it works in about 60% of patients globally, and then 25% for specific neurological disorders. Then there's step two, and that's where I've changed things around. Pardon me. The rest of step one are also inclusive of cromolyn
Hmm.
and ketotifen, which is a type 1 antihistamine drug that's compounded, and montelukast, which is also called Singulair. And the problem with that drug is that somewhere in the neighborhood of 10 to 20% have psychological disturbances, anxiety, depression, and it has a black box warning.
Hmm.
So that's a concern. So if somebody has interstitial cystitis or asthma or severe seasonal allergies, I may well put somebody on montelukast or Singulair.
Okay. I rarely use it. I rarely use it. Yeah.
So
Mhm.
that's step one. Step two would be other kinds of xylutin, which is like montelukast but less likely to cause problems in the brain. And then insurance doesn't like to pay for that drug either. And then where do I put things now? Well, on the basis of a study that we just published on GLP-1s, which now are called GLPs,
This was published in the which journal was it?
brain, brain behavioral modification. Yeah, so it's, if you just do Weinstock or Afrin GLP-1 and MCAS, she'll come up with the article, and it's available to anybody to read. And so we had 89% of our patients, 47 in this case series, get better. A number of different things, crazy things that you wouldn't think about, but including things like POTS or tachycardia, hives, or food intolerance. Wide spectrum of things that I tabulated here. 23 out of 47 had improvement in gastrointestinal symptoms. 22 out of 47 had dermatological improvement, including edema, 6 of them, flushing, 5, urticaria, 3, alopecia, 3, pruritus, excessive sweating as well. Neuropsychiatric problems got better with GLP-1s in 28 out of 47, including brain fog, anxiety disorders, amongst two.
Duration of use, Doc? What was the duration of use and what was the average dose?
So, very good question. In a way, it was unfortunate, but everybody, all the 5 authors, did put in their experience, and everybody had a different dose that they used. Even though we called it low dosing, some were actually higher dosing or worked up to high dose. But we tried to get people to prescribe low doses, and some people did, some didn't. So, maybe that explained why a number, had nausea. But when they got back down on dose, the nausea went away. The same thing for constipation.
But they still had control of the MCAS.
Yeah, that's why we think that the low dose,
Yeah.
the microdosing, is the critical thing.
Yeah. Excellent. I'm so excited about that paper. I think it's another thing in our toolbox that we can use. I think, was there another publication in terms of use of GLP-1 in another autoimmune condition, or has this been?
Well, people are using it in neuropathy, diabetic neuropathy, and then there are also issues using it in sleep apnea. And by the way, if you got somebody with sleep apnea, check for Ehlers-Danlos syndrome, because it's their neck is, very soft and closes things off.
Yeah.
And
we've seen benefits in Crohn's and IBD. We've
yes,
seen benefits of the use of GLP-1.
And it's going to be applied to everything. I think that little infants are going to get a special line, and they'll get a steady state of GLP-1s.
Mm-hmm.
So,
So
I'm kidding, please.
I'm like, oh, okay. How about medications? I know in step 3 therapy, you talk about Xolair and Dupixent. Right?
Okay, so, well, I don't know if there's no studies on Dupixent and MCAS, and I don't know
I haven't
if
seen
it works or not. It doesn't actually make sense to use it, but one of the allergists at the hospital at the university uses it, and I don't know if it works or not.
Why are you saying it doesn't make sense? Because of the mechanism?
Yeah. Basically, there's this very internalized cellular abnormality of the ILs that are the factors, the driving factors for eosinophilic esophagitis and asthma and so forth. But none of that really is a part of MCAS pathophysiology, to my knowledge.
Mm-hmm.
So what else do we use? Well, I've covered a couple of case series using imatinib, which goes after the KIT gene that's abnormal. Seems like a great idea, and about half the patients in it worked wonders. And then hydroxyurea, which used to be used for CLL, leukemia, is now only used basically for, brain fog. That's not a good thing for MCAS patients, but basically for kids with sickle cell. So the mast cell is active in sickle cell. Hydroxyurea is used in a low dose for sickle cell, and I found it to be very helpful in over 50% of patients who had MCAS, including one patient who took hydroxyurea, had been depressed her whole life, had suicidal thoughts since she was a teenager, and now as a 60-year-old is doing so much better
Wow.
for that. And she's one of the case series that we published in
Okay.
2023 on neuropsychiatric disorders at MCAS. And that's amazing. I think there's probably going to be a role for tofacitinib, which is Xeljanz, uh, because it does affect the mast cell,
So, okay,
and,
interesting.
and it's in, you know,
Yeah.
uh, rheumatoid arthritis and ulcerative colitis, which can cross over in terms of symptoms with MCAS.
Hmm. I've used IVIG in probably a handful of patients, three or four. What's your success rate?
IVIG,
Uh huh.
if you can get it, it can be helpful. So that's where I go back to my patient in Alaska, who's actually got better and was able to move to California
Mm-hmm.
and not be affected by the heat so much.
Mm.
But the fact is that IVIG is difficult to get. It's
Approved.
very good for autoimmune POTS. We
Mm.
can get autoimmune panel at Mayo,
Mm-hmm.
and if it's a positive, then you might be able to get it. If somebody has gastroparesis and you're looking for the GAD65
Mm-hmm.
antibody, and you have that positive, you might be able to get IVIG. But in the study that I mentioned early on in 2018, the case of this poor woman who is now great with IVIG, LDN, and SIBO therapy. We also looked at other people through a questionnaire online, and many patients did really well with it. And I've had subsequently approximately 5 patients on IVIG, and they could be really benefited.
Hmm.
But it's a lifetime thing, you know.
It is. It's a lifetime. Yeah.
It's an
Yeah.
expensive thing.
Yeah. Very, very. And with GLP-1 now in one of my patients, I'm thinking that may actually be a good one to a good alternative for her to try if we can, because her response on IVIG has not been fantastic. It hasn't been that great. It hasn't been that great. Okay. That is, have we got there are many more drugs and we can go on forever and ever, but the biggest challenge is getting them approved. Um, for the patients, getting them approved. And I find one of the biggest challenges is actually dealing with some of the foundational nutrition, lifestyle, the stress, the impact of stress on their symptoms. Yes, huge. Yeah.
So, can I end maybe with a story of a
Yes.
patient? So, I met this gentleman at age 50. He didn't have multiple symptoms, but he was in and out of the emergency room, urgent care, and hospital with nausea and vomiting and abdominal pain. And then when things got worse, diarrhea. These attacks occurred frequently. Initially, it was not clear to me, but he said when he would go to work and conventions, uh, and he'd fly there and he'd get sick and he'd go to the emergency room. And so I asked, what kind of conventions? And it turns out he was a paint salesman his whole life. And so initially I was thinking, oh, maybe it's, you know, atmospheric changes and whatnot going on in the airplane that he gets sick every time he gets going. But in fact, it was exposure to paint. At these
Hmm.
conventions, they take off the lid and they look at it and they brag about it. But this organic, volatile chemical goes into his nose, into his brain, so to speak, into the body that has effective mast cells that are bad. And so I examined him closely. He did have some hemangiomas. I said, "What about the hemangiomas? Are those symptomatic?" And he said, "Yeah, during these attacks, they would swell up, itch, burn, and then they'd calm down and decrease in size."
Hmm.
I said, "Oh, that's interesting. That's two body parts, your gut and your skin." And then I said, "Let's do blood work." His prostaglandin was high. He got put on step one, step two, step three therapy. Nothing really worked. A little bit. I did tell him, to wear a mask around chemicals and try to be away from it, but he still had to work, and that was a problem. And so I put him on imatinib, and dramatic improvement.
Hmm.
So that is a chemo drug for a rare kind of cancer, but low dose imatinib made a big, big difference. Then I said, you got to retire or do something else. And so I heard from him a few months later, and he said, I'm doing great, doc. I've quit. I'm doing well. I don't have any stress. My wife and I got divorced. There's no stress. I'm happy. And I'm thinking about tapering off the MCAS meds. I said, okay.
Okay.
And so then he had a colonoscopy with me a month ago. I see you're not on any medications. He said, no. New girlfriend, old wife is divorced. I have no stress. I'm making a lot of money from all the money I put into Sherwin Williams, and everything's great. And I had written him up for a case series on imatinib and him being the propositus because it works so well. But it shows you the importance of getting rid of stress.
Yeah.
And there are programs, DNRS,
Yeah.
GupTA method, a number of them that are out there that can help cut down on stress, which is a big factor.
Yeah.
But I don't want to say this is a stress induced illness. This is a genetic mutation. This is a disease. It's got symptoms, it's characteristic symptoms. It's got genetic abnormalities that if you got your blood tested in Germany where they do this specialized testing, you could find the genetic mutations. It's got blood tests and urine tests that are biomarkers.
Mm-hmm.
It responds to medical therapy. This is a disease. And for all the patients out there who have been suffering from things that their doctor couldn't diagnose, there's a good chance it's MCAS. And then for the doctors, as I put in this article for American Journal of Gastroenterology, once you've seen the triad, you can't unsee
You
it.
can't miss. Yes, you can't miss it. Yeah,
Yeah.
absolutely. I think that's a beautiful place to end. Dr. Weinstock, you are, so I'm a gastroenterologist, also trained in functional and integrative medicine. That's exactly what we do in integrative and functional medicine from start to finish. You're describing exactly the protocols that we are taught and how to investigate multi-systemic disease states, right? So when I see MCAS, there's usually an underlying issue, right? There's some other underlying. It could be Crohn's. It could be EDS. It could be another underlying issue or another underlying big foundational disease. I think where MCAS adds to it, like MCAS is triggered by it. That's what I'm
Or
thinking.
vice versa.
Yeah. Do you think
Honestly,
or
I
vice
think when
versa?
you
Or
go
vice
and look at the
versa?
childhood, you look at the
Yes.
kids' teen history
Yeah.
and so forth, they're cooking their
Yeah.
MCAS. And
It's coming later.
yeah, my 10-year-old had multiple panic attacks, anxiety, would go to the school counselor, try to get out of school, had abdominal pain, nausea, developed, lost 15% of his body weight. And he was 10, and I told my daughter, get him tested for MCAS, start him on antihistamine, see what happens.
Mhm.
Of course, she didn't do what I said, but then she started listening to a podcast that I did, saying, "Oh, all these are all symptoms that kids have."
Yeah.
She said, "Dad, you're talking about Max." I said, "Well, all right, let me diagnose him." And so he started antihistamines, Leodolin. He got diagnosed first with a blood test and
Okay.
the biopsy down in Nashville.
Okay.
Not me doing it. I'm only seeing adults, but I know that it starts in childhood, and it definitely gets worse with anxiety. But it's a driven disease by mutation, and so basically, with minimal therapy, minimal treatment. He's able to eat everything he wants. There's no nausea. There's no bruising. He had bruises up and down the back of his legs.
That's
Where did
all.
they come from? I don't know.
So
And
he's avoiding the triggers. Is he still avoiding what we think are the triggers and then
yeah, yeah,
needing
he actually
chemotherapy
did
or
everything. You know,
yeah,
I said that basically after he was diagnosed, let's go on a gluten-free diet and see how you do. And he said, Poppy, no, I'm going to challenge myself all this way, and really virtually no food triggers.
no food triggers?
No food triggers for
Yeah.
him.
Yeah.
So anyway,
So it's vice versa. It could be vice versa.
yeah,
But I do
you
I
know, I
do
think you are adding. I think that often MCAS is the underlying disease. You add a bad vaccine like Gardasil is
mhm,
a bad vaccine.
mhm,
The HPV vaccine in Europe is not associated with POTS,
mm,
but it is here, and
mhm,
it's because you've activated the mast cell, and then the viruses we've got are a real problem, especially COVID.
mhm. Oh, absolutely, absolutely, absolutely. Well, but I do see. I mean, I could talk to you forever and talk honestly, but so I think there's a mutation. But so, for example, I see patients with IBD and have MCAS on top of it, right? And so generally they'll see a gastroenterologist who said, let's switch medications, let's switch right away, let's go to another biologic. But if you hear all of their symptoms and you do the testing, you're looking at diet, nutrition, you're looking at the lab work, you're also looking at, staining CD117 when you can,
Mm-hmm.
and you treat that underlying mast cell activation, they can stay on their meds, right? So I guess the question for me then is, was it MCAS all along, but they have evidence of Crohn's, they have stricturing disease, they have fistulizing disease?
I don't see that much of an overlap. Certainly, many patients, I don't have the percentage, have celiac disease,
Mm-hmm.
and then they go on a gluten-free diet, and then they're still symptomatic from MCAS,
Okay,
just like my patient that I presented early on
right.
today. Um, so I think there's some diseases that are, you know, basically concomitant disorders, more comorbid disorders, such as restless leg syndrome
Yep.
and tinnitus and SIBO. We didn't talk about SIBO, but yeah, SIBO coexists, and you have to treat the SIBO for the MCAS to get better.
Yep.
I just don't see a lot. I have one patient with lymphocytic colitis who's got MCAS and got better with tofacitinib
Oh,
for both conditions,
okay.
which has not been reported um, simultaneous anyway. So, I
You
just don't
don't
see
see a
as
lot of
much.
concomitant.
Maybe your
Okay.
referral, your people who are coming to you with more diseases, and you have to look at the Venn diagram. Okay, you've got a big following for Crohn's. Okay, but 17% theoretically of Crohn's patients will have MCAS
Yes, yeah,
because 17% of the population has it.
absolutely. That's a very important point. Yeah, we are definitely underdiagnosing. Well, this was an amazing conversation. I'm going to have to split it in two because there's so much information. I am going to post in the comments, guys. I'm going to be posting the questionnaire. The I'm also going to be posting the treatment guidelines that you have outlined in terms of the different steps, and I will be posting the two articles published by Dr. Weinstock. I think the one on neuropsychiatric, response to treatment of MCAS is really important, and the most recent one on GLP-1s and the response for our patients with MCAS is very, very important. Very important conversation. Are you going? Are you speaking on any of our GI platforms? I mean, I want to see someone like you at DDW, at ACG, at AGA, because we're seeing so much in clinic, and I don't think we know how to treat our patients.
So there, 3 years ago, when ACG was in Nashville, there was finally somebody at a major meeting talking about the triad.
Okay.
Okay, so that's big. And then I was invited to write that article on
Mm-hmm.
MCAS and by one of
Policy.
the editors to have a good spot. And I had a number of emails from people saying, I need to start thinking about this.
Mm.
And I'm going to end this from an important perspective. MCAS is not taught to GI fellows. It's barely taught correctly to allergists, in my opinion. And it's not taught to medical students when they're most open minded. And so that is a big problem. And so when is that going to change? Well, I think it's going to change when people have a drug salesman come into their office, say, we've got this new drug for MCAS, and it's going to be the answer to all your patients' problems who have this disease that's been unrecognized and undiagnosed. And it's going to help you because you won't be getting calls left and right and so forth. And then it's also going to be changed when a medical school dean
Mm-hmm.
has a granddaughter with the triad, and he realizes his professors are dopes because they don't know how to treat this.
Yeah,
I'm
absolutely. And
serious.
yeah, that is 100% true. They're going to invest the time and the money and the efforts and the research into making this common as part of a curriculum, right? Just very important. Dr. Weinstock, thank you so much for your time. This was an amazing conversation. I'm going to split it in two because there's so much depth here. And I want everyone to really be able to understand and appreciate this diagnosis. Again, my name is Dr. Vivian Asamoah. If you're on here, you're part of our YouTube channel. Thank you for subscribing. Share this with others, or you're part of our private Facebook group, Natural Gut Relief. And we'll see you next week. Thank you.
Thank you.